So to start off, thank you so much again for sitting down to speak with me today. I really appreciate it. So to start off, how has the transplant eligibility criteria changed, and if so, how? And are you trying to delay transplant in most patients?
Yeah, due to COVID-19, we've reassessed both our induction and transplant eligibility. So in general, we are trying to continue with the procedures as we would usually do. So for transplant, especially in the frontline setting, whether it's acute myeloid leukemia, acute lymphoid leukemia, we are continuing to proceed with allogeneic stem cell transplant. One thing we do is we check for the COVID-19 before proceeding with transplant. And if the patient is negative, we usually are proceeding in the frontline setting. Now, in the relapse setting, we are becoming a little bit more conservative about selecting both the timing and the type of transplant. So patients who are in remission, but maybe who are MRD negative, we may consider giving them one or two more cycles of therapy to try to get them into a deeper remission, or to try to buy some time and then consider doing the transplant at a later time point. And I have a number of such patients in my clinic, for example. So yeah, I mean, if we think it's absolutely needed, it's curative, and the patient is in a very good remission, we don't want to delay, we are proceeding. But in situations where we think that we could safely, by 6 to 8 weeks, we could proceed with one more cycle, and it may give us time to hopefully get over the peak of COVID, which we hope will be in the next few weeks, then we are deferring that transplant in those situations.
Fantastic, thank you. And so what about bridging therapy? Are you putting patients on longer dosing schedules to delay transplant?
Yeah, so most of our patients are on treatment with clinical trials, and if we are proceeding to transplant, especially in, let's say, the frontline setting, we usually try to do so after either the induction or induction plus one consolidation. If in today's era, if there are patients who are either concerned or for particular reasons, let's say given their age, comorbidities, we are worried the transplant may be risky, especially with a high potential incidence or a severe occurrence of COVID, then we may give them one or two additional consolidations. Each consolidation usually lasts 4 to 6 weeks. So if you give one consolidation, that'll buy you 6 weeks. If you give two, it could give you another 12 weeks. We're not really changing the cycles per se, or the dosing or intensity of therapy. We're just giving more consolidation cycles. And in the relapse is the same thing. When we're using targeted therapies, either a single agent or in combination with azacitidine or with venetoclax, the cycles usually run between 28 to 42 days, depending on count recovery. And I have a few patients where I'm giving them one or two additional cycles, even though they may have a donor ready, because they may not be MRD negative, or there may be concern of doing the transplant, given that this may be the peak time of COVID. So we just use additional cycles to buy additional time if needed in this situation.
Fantastic. And so what about the use of hematopoietic growth factors? Has the utility of that changed with COVID, and how?
In general, no, and I think there's a bit of a controversy on this aspect as well. We are not really sure whether hematopoietic growth factor use at a broader level is necessarily going to be beneficial. I have spoken to colleagues in other countries where they have actually noticed a paradoxical, less severe COVID presentation in patients with AML or ALL who come in with very low neutrophil counts. Now, these are case reports, individual reports. It's hard to say, but we do know that the terminal stage of COVID is often a hyperinflammatory stage, similar to what we are seeing with cytokine release, high levels of Th1 type cytokines such as interleukin-1, TNF-alpha, ferritin, LDH. And the concern is that if we gave if we gave growth factors like Neupogen to increase the white count, it may actually unmask an inflammatory response. So a lot of this is kind of theoretical or based on case reports, but we're basically using the same guidelines that we did for growth factor use, like Neupogen or Zarxio, which is basically people who have very prolonged neutropenia after receiving induction and consolidation, which means beyond 42 days, or those who are admitted with any kind of severe infection, ICU stay, sepsis, prolonged fever beyond 70 to 96 hours. We're not routinely increasing our use of Neupogen Neulasta at this time based on COVID incidence or occurrence.
Great. And what can a greater use of growth factor support do for patients at risk for COVID-19?
Sorry, would you repeat the question?
Yes, of course. So what can greater use of growth factor support do for patients at risk for COVID?
Yeah, so that's what we don't know, whether the use of growth factors in an asymptomatic patient at risk for COVID could potentially prevent the infection. That is the hypothesis for using them. But we're also worried that if they do have a subclinical COVID infection and their neutrophils are low, they may not be able to mount the hyperinflammatory response. And when we give them Neupogen and get their neutrophil count up, is it possible that they will now have functioning higher T cells that could then produce a cytokine release or hyperinflammation, which is why we're not really using growth factors more often than we did as a standard practice in the past.
Great. And are there any issues now with using erythropoietin stimulating agents given the limited blood supply?
Yeah, so erythropoietin agents such as Aranesp or Procreate are usually used more predominantly in MDS and in certain types of myelofibrosis that present with anemia to try and maintain the hemoglobin at a level that will not cause clinical symptoms. We have not changed our practice on the use of these agents. There was initially a shortage of blood during the initial first weeks of COVID, and we did reset our transfusion threshold at a slightly lower level, especially for those patients who are younger or asymptomatic. We are now seeing that there is more availability. We are of the blood products. It's still not back to baseline, but we are able to start transfusing more if needed. So we're not using growth factors more frequently at this time. Now with COVID, there's also a concern of DIC or thrombotic events. This is emerging in more and more patients, especially in the peri-surgical time points. And so again, when we use growth factors such as Aranesp, these are also known to slightly increase the risk of blood clots and thrombosis. So I would be careful to use them very frequently beyond how we've used them traditionally in MDS or myelofibrosis.
Fantastic. And are there any thrombocytopenia related considerations currently given the limited blood supply?
Yeah, I mean, we are general, of course, worried about thrombocytopenia in our patients. It is associated with higher risk of bleeding events. And in general, we do try to keep the platelet count above 12. Historically, we would often try to do 15, but in the current era, we're shooting more for 10 or 12 in patients who are not actively bleeding or having signs of bruising. In those patients, we may actually go for a higher platelet level. There's no really good platelet enhancing agents in the setting of leukemia that have shown effectively ability to increase and maintain platelet count without side effects such as liver problems or bone marrow fibrosis. So in general, we are continuing to monitor platelet counts and transfuse as needed. We are thinking in some of our patients who are, let's say, above 60, where they may be candidates for both intensive chemo or for moderate or lower intensity therapies such as HMA, hypomethylating agent plus venetoclax. There was always a debate, especially in people who have adverse cytogenetic TP53 complex or bad risk features, that HMA venetoclax may be equal, potentially even better than standard induction cytarabine anthracycline. And now I think with the COVID, there is more enthusiasm and more push to use HMA venetoclax in those borderline patients between 60 to 75 who may have moderate fitness but may have intermediate adverse cytogenetics or adverse molecular features where we may have hesitated and not be sure which one to select. We're now maybe going more for HMA venetoclax, which usually has less transfusion support requirement, less inpatient stay, less prolonged myelosuppression. So this will actually hopefully provide us some very useful data that will inform us in the future in this borderline population of 60 to 75 with modest or moderate fitness. Is there a clear role for HMA venetoclax to be used preferentially over induction-based therapies?
Well, that's great to hear. And what other measures and best practices are you implementing in practice given the COVID-19 pandemic?
I think the biggest thing is basically, hyper accentuating the standard precautionary measures that everybody's heard of in the news and everybody has heard of from their institutions, which is hand hygiene, washing the hands very frequently with good antiseptic soap, and doing it for 20 seconds is very critical. 20 seconds is actually quite a long time. Most people, when they start counting, they realize they probably never washed their hand for 20 seconds in their life. And I have noticed the same thing. So you really have to count and wash very carefully. Watch frequently, especially any time that you have left the house or left your office, gone to clinic, gone inpatient. The second thing is we are using mask precautions as has been recommended by the CDC. So we use mask at all times when we are in the institution or around the institution. And even outside the institution, I do prefer to use mask whenever I can. So that's one other important precaution. The third thing is, of course, any early signs of fever, shortness of breath, cough, respiratory distress, whether it's your patient or whether it's an employee, must be evaluated very emergently. And we do have now access to rapid COVID testing, both for employees as well as for our patients. So we will try to identify those patients quickly. And whenever interacting with patients in clinic, whether they are COVID suspected or not, use of proper PPE, so mask, gloves, hand washing between each patient if possible, as well as minimizing contact. We are not shaking hands with patients. We're trying to minimize contact as far as possible. I think all of these are the key, precautionary measures that we are trying to implement very, very rigorously. Even in a social setting, trying to minimize the number of people in a get together actually to less than 5 if possible, and maintaining distance between people, not sharing food, not sharing drinks, all of these things which sound very simple, but really being implemented at a very rigorous level.
Great, that's great to hear. And I know that a lot of institutions are experiencing shortage in supplies such as face masks or gowns. Are you at your institution experiencing any of this? And if so, how are you handling it?
Yes, at this time we don't have any acute shortages, but we're all very concerned about this, and we have not been hit by a number of patients like has been seen in the Northeast or California. But that does not mean that this situation may not change, and it is always possible that we will either see a chronic kind of COVID infection over many months, as opposed to the large spikes that we're seeing in New York and other very large metropolitan systems. So we are being very precautious and conservative in our use of PPEs so that we do not run into an acute shortage scenario. There are many efforts ongoing, both at the national and international level, to enhance production and to bring it to the large institutions, hospitals across the US, Italy, Spain, and hopefully in the next few weeks, if we can hold out, these will be available. But I think it is very important for the non-medical individuals to try to avoid purchasing excess large amounts of PPE, hoarding these, trying to reuse masks if they have them available, because I think it is critical for the nurses, physicians, especially those who are actually seeing COVID patients, both in New York and other institutions across the country, to be able to use these to see their patients and keep themselves and their patients safe.
Definitely, that's a great point. And what efforts are you making to address the disruptions in access to care caused by COVID-19, such as telemedicine, making more phone calls? Are you using apps or anything else?
Yeah, I mean, that's a big change in our practice. I think there's at least a 5 to 8 time increase in the number of telephone calls that I am doing daily, not just with patients, but equal or even more with the local hematology oncology providers who, have done an outstanding job. They have been a great assistance in doing management of our leukemia patients locally, with very close collaboration with the physicians, the research nurses, the data coordinators, and we've been able to actually continue almost all our patients on treatment locally with their support, where we ship out the oral component of the medication and they will do the IV component if it's something that's available standard of care. So we haven't seen a huge disruption now by the nature of the travel bans, as well as national reduction in flights. The number of patients that are coming to a tertiary referral center such as MD Anderson have gone down. And we are hoping that this situation will start improving as we get through the peak. So officially, we have not closed any of our major studies. We continue to be able to follow and monitor the patients who are already on studies. And we are using and working very closely with our colleagues in the local community setting, hematologist, oncologist. And I think in the future, this will be very important, because this may actually show us that we actually can work very closely with community hematologists and oncologists, allowing us potentially enroll more patients on trials and then allow them to have local care with the oversight and monitoring of the principal investigator or treating physician, MD Anderson. So this may actually be a bad scenario, of course, in general worldwide, but may actually help us develop new strategies and approaches that may, in a few years, turn out to be helpful for patients, trials, and institutions.
That's very interesting. Thank you. And lastly, what can people do to help healthcare professionals and patients with cancer during this pandemic?
Yeah, I think the biggest thing, and unfortunately, I think, in the US, it's taken a while for this to really start penetrating, is to really take the precautions very seriously. I mean, COVID is absolutely a severe disease. It is very prevalent. The number of cases is going up. We do not think that it is going to be very short-lived and go away. We hope, but we don't think so. We expect this will go on for a few months. So I think, it may be a big social or emotional impairment, but I think isolating oneself or avoiding contact externally or minimizing it if it cannot be avoided, as well as taking very, very stringent cautionary measures, hand washing, using of antiseptics, using a mask, avoiding physical contact with external individuals as much as possible, are all, things that will help. As they say, try to stay home as much as possible, which will help us get less patients, which is probably the best thing we can see. And other big burden, especially being a cancer center for our patients, is that we have had to, like most big centers across the country and world, limit visitors or not allow visitors in many cases, just to minimize the community spread within the hospital. And this is something that, of course, people are many times upset. I would be upset myself and passionate about, but this is something you have to realize we all are having to do. Nobody wants to do it at all, but we have to do this for the benefit of those patients themselves, as well as other patients who are in the hospital. So just to try to realize and be patient from that aspect, which I will say 99% of our patients are really stars at doing and have been outstanding at, managing around this difficult situation.
Fantastic. Well, thank you so much for taking the time to speak with me today. Is there anything else regarding COVID-19 and oncology that you wanted to talk about?
I think the good thing is that from a clinical research perspective, which is one of my main areas of focus, we are seeing that the research community has really come together to try to identify therapies for COVID, as well as potential vaccines, as well as serum strategies. And I think we've never seen this in a pandemic where we have been able to mobilize so much research data, get publications out so quickly as we have with the COVID-19. So we're very optimistic. We're very hopeful that we will eventually develop serum and vaccine-based approaches that will conquer and overcome the COVID. The hope is that we can just minimize the number of cases and mortalities by that time. So let's all work towards that end, hopefully sooner than later.
Great. Well, thank you so much for taking the time to speak with me today. I really appreciate it.
Thank you very much.
I hope you have a good day.
Okay, you too. Take care.